dear colleagues, it's a great honor for me to be the first presenter of today and to give you a little introduction in my PhD topic about predictive and prognostic biomarkers in urooncology. I strongly believe that with the development of precision medicine and individual molecular targeted therapy, the life quality and expectancy of oncologic patients can be highly improved. And in line with this vision, my personal mission is to find biomarkers which can guide optimal therapy sequencing in both prostate and bladder cancers. And according to this vision and mission, we set up two specific goals for the previous academic year. In both projects, we are assessing the so-called BRCA or BRCA positive metastatic castration-resistant prostate cancer patients. So let's talk about the first project, which we have already submitted. Why should we talk about prostate cancer? Because prostate cancer is the most common solid type of malignancy in the male. 1 out of 8 men will develop it during sometimes their lifetime. And 10% of the advanced cases are the so-called BRCA or BRCA mutation positive ones. Well, BRCA is probably one of the most well-known genes of all time because that was the one because of which Angelina Jolie underwent a prophylactic mastectomy. But why is it important for us in urology? Because the loss of function mutation of the gene leads to a much more aggressive prostate cancer disease. These patients' survival is 50% worse compared to the wild type ones. And besides their different biologic attributes, these patients represent a different clinical entity as well, because they respond differently to various treatments. We've got an on-label targeted therapy for them, the so-called PARP inhibitors, but currently we can only give them in a later line treatment setting. But how do these patients respond to the standard first-line available treatments to abiraterone, enzalutamide, and docetaxel remained unclear in the past decades. So our aim with this meta-analysis was to assess the therapeutic response to abiraterone, enzalutamide, and docetaxel in this molecularly selected subgroup of patients. Well, this kind of setup would cry for an interventional design, but during our preliminary research we haven't found enough eligible articles and any article with this design. So we ended up by performing a descriptional meta-analysis where our primary question was concerning a PSA 50 response rate, which is defined as a PSA decrease at least 50% from the baseline level. And our second question was concerning the progression-free survival of these patients, and we used individual patient data and the random effect Cox regression model to try to compare the various treatments with each other. We've performed a systematic search, and we ended up with 17 articles. And now let's see the results. The first-line treatment, the PSA 50 results in the first-line treatment setting, we could assess almost 100 patients. And with abiraterone treatment, 52% responded, for enzalutamide, 64% responded, and for docetaxel, 55% of the patients responded. And based on this analysis, we can see that enzalutamide-treated patients had the highest response rate. Now let's see our progression-free survival. On the following Kaplan-Meier curves, you can see with the dashed line the enzalutamide-treated patients and with the continuous line the abiraterone-treated patients. And you can see a clear benefit of progression-free survival towards enzalutamide. And what happens when we fit our random effect Cox regression model on our individual patient data? We detected a 53% lower risk for progression in case of enzalutamide compared with abiraterone. Now, to sum up things, on the one hand, we've got some strengths of this study. First of all, this is the first meta-analysis providing a comprehensive overview with these outcomes for this novel subgroup of patients. And I have to add that we could use individual patient data, which was particularly important in our analysis. Obviously, we've got some pitfalls as well. First of all, I have to mention the small sample size. Secondly, as I've told you before, there are no studies comparing directly the agents. Our progression-free survival was a composite outcome, and BRCA mutation test methods may have differed among the different studies. But what can we conclude from all this? Well, we showed that BRCA-positive patients respond to all standard first-line treatments. And we have to add that we saw that enzalutamide treatment had the highest PSA 50 response rate and the benefit in terms of progression-free survival compared with abiraterone. And what can we do with all this, our general practice? Well, we can only say that these patients respond to all first-line treatments. However, there can be individual differences between the agents. But with this analysis, we would like to highlight the importance for molecular marker-driven interventional trials, which are comparing abiraterone, enzalutamide, and docetaxel, and which could give us a higher level of evidence in this topic. So, as an overview, we have submitted our article in the end of July, and the decision is on the way, so we are waiting for it currently. So now let's talk about the second project, which is pretty much related with the first one. Our population is the same. We are assessing the BRCA-positive and CRPC patients, but we are assessing the later line treatment options in this meta-analysis. So you have seen that we can choose among at least 7 different agents in the therapy for advanced prostate cancer, but despite this wide range of available treatment options, the 5-year survival of this disease state is only 30%. So we still have a long way to go in optimizing our treatment sequences. And in the later line, we've got the on-label PARP inhibitors, targeted therapy for BRCA mutants, the PSMA ligand therapy, the cabazitaxel chemotherapy, and the platinum treatment, which is a widely used but off-label treatment for BRCA-positive mCRPC. So our aim in this study was to assess these later-line therapeutic options in the BRCA-positive mCRPC disease state. Our clinical question and design was completely the same as it was in the first one. Our first question was about PSA 50 response rates, and in our second question, we were assessing time to event variables based on individual patient data with the random effector Cox regression model. We have performed our systematic search. We ended up with 26 studies, and fortunately, I can show you our PSA 50 results. We could assess more than 700 patients in this analysis, and in case of PARP inhibitors, 69% responded. For platinum treatment, 77% responded, and for cabazitaxel and PSMA ligand therapy, 28 and 50% responded. But you can see moderate heterogeneity in the case of PARP inhibitors, but we made subgroups based on these types of studies, and it turned out that the prospective versus retrospective study design is in the background of the 60% I-square test, which shows us the heterogeneity. And now let's focus on only the PARP inhibitor and platinum treatment. The PARP inhibitor is on-label for BRCA-positive, while the platinum is off-label, but have been used in the past decades for these patients. And you can see that they are pretty much really close to each other, with the 69% response rate and with the 77% response rate. And it brings a really important clinical information for us. And currently, I have to add that we are still waiting for the results of the progression-free survival and overall survival. Well, to sum up things strictly based on PSA 50 results, we can say that this is the first meta-analysis with these outcomes, and in this patient subpopulation, we could reach large sample sizes with PARP inhibitor and platinum treatment, and we could use individual patient data here as well. Of course, we have got some limitations too. With PSMA ligand therapy and cabazitaxel, our sample size was pretty low, and there are no studies comparing directly the agents. And there are prospective trials available only for PARP inhibitors. For the others, there are only retrospective designs. So what can we conclude from all this? We can say that BRCA-positive patients respond with PSA 50 to later line treatments as well. but the PSA50 response with platinum is comparable to PARP inhibitor, which leads us to the very important clinical implication that platinum treatment may be a valid treatment option for BRCA-positive mCRPC patients. However, we have to note that the prospective, molecularly selected prospective trials with platinum, and then after molecular marker selected interventional studies comparing platinum with PARP inhibitors are needed to further assess this question. As an overview, you could see these two projects, and I would like to thank you for your attention with the words of St. Francis of Assisi, that first you should start doing what's necessary, then what is possible, and suddenly you are doing the impossible. Thank you very much for your attention.
I just want to ask you, how exactly did you do it that you found out that the reason for the high heterogeneity in the second one is the nature of the studies, that it's either retrospective or prospective? Mm-hmm.
We formed subgroups based on the study design of the PARP inhibitor treatments, and then we formed a subgroup with prospective trials and with retrospective trials. And then there was no significant subgroup difference between the two subgroups. However, the I-square lowered down to 25% in the prospective group and to around 0% in the retrospective group. So that's why we think that, however, the difference between the PSA50 results were not significant, but the heterogeneity decreased in the subgroups.
I just wonder that very nice studies and very good progress. And now you kind of made two meta-analyses, and then you identified many actually therapeutic targets. So are you, I mean, in the clinic, you and your colleagues ready to do actually randomized clinical trials to step forward?
Mm-hmm. Thank you for your question. Well, the prospective trials with platinum treatment are on the way. So if we search the clinicaltrials.gov, and there are trials assessing this question, but it would be a really, I don't think that there is enough evidence to compare platinum and PARP inhibitors in a randomized trial. First, we need prospective data on platinum treatment, but I don't know who would, how should I express myself, who would finance or help performing this, because PARP inhibitors are new novel agents with a patent, while platinum has been used for many decades now. But we should keep an eye on the literature, and if something comes up, then perform our analysis and then synthesize again and check if there is enough evidence to perform ethically prospective trial in this topic. But what we are planning now is that to summarize our own institutional experience with platinum and PARP inhibitor treatment in the BRCA-positive prostate cancer patients subgroup.